Hi, welcome back to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor for JAMA Network Open.
And I'm Mike Berkowitz. I'm the Electronic Editor for JAMA and the JAMA Network.
Thanks for taking a break last week. I was off on a family vacation. Sorry to miss out on the science. Of course, if you're following along as usual, please respond online with comments, questions, anything else. Comments about my shirt again, Min, if you want. You can always just tag us or reply to the threads on Twitter. Respond right under the video as a comment under Facebook or YouTube. And of course, we'll try to get to those questions even later if you're not following along live.
And my understanding, Seth, is that we have a breakthrough innovation today. Is that correct?
We do, and we're going to get to that with our first paper.
Awesome. What's the breakthrough innovation?
All right, so first paper is the comparison of a prototype for indications-based prescribing with two commercial prescribing systems by Pam Garabedian and colleagues. And our new feature today is that Pam Garabedian is joining us via Skype.
Hey, Pam, welcome.
Hi, thank you.
Thanks for joining us, and thanks for your paper.
Thank you.
So basics of this paper, we all know EHRs have, let's say, a number of limitations, particularly in usability.
Understatement.
Right. And one of the big differences, basically the status quo for most EHRs is that when physicians put in orders for medications or prescriptions, that we just kind of put in the prescription. We say, I'm going to give the patient metoprolol, I'm going to write for him metoprolol. It has nothing to do with the actual indication for why I'm giving the patient metoprolol. Pam, why don't you tell us about what was different in your study?
Yeah, so the thing that we were focusing on is trying to bring the indication at the focus of the electronic prescription. So we designed a prototype that started with the indication, and that in that way it could sort of suggest some drugs of choice for the physician to select from based on the indication, and the way that we designed our prototype also based on certain patient factors and clinical guidelines. Insurance formulary information, FDA status was also included. So because we started with the indications, there were a lot of other things that we could do and build off to hopefully make prescribing a little bit more efficient, safer, and easier.
Was the indication auto-populated from the problem list or the billing codes, or is it something that the physician manually enters?
Yeah, so the way that we designed our standalone prototype was that we had the problem list on sort of the left-hand side screen. So the physician could click on an existing problem, so start from there if they wanted. There was also a search bar where they could search for any drug as usual or a problem. And they could go from there as well. So we had it was flexible enough that they could select from an existing problem or just search.
And just to clarify, Pam, I think you did this as kind of a simulation, not in actual clinical encounters.
That's right. Yeah. So our prototype was a standalone prototype that we built. We had a small database that we designed ourselves for these clinical scenarios. We also built those same scenarios or test patients into Epic and Cerner, which is what we used to do this simulation study. And we compared the prototype to Epic and the prototype to Cerner.
Which is awesome. I'm going to let Seth describe kind of what happened, but I just want to ask you the question whether you thought physicians behaved differently because they knew it was a simulation and not real clinical care. Do you have any observations on that?
I think that's always a possibility. For the most part, they only behave differently with the prototype. So I think for their usual system, they used it as they usually do. For the prototype, they were curious. So they may have spent more time on the prototype than even they normally would if it was something familiar to them. So they were just looking around, checking things out, reading more things than they normally would be reading through things.
Right, partly because they probably didn't have the time pressure of a clinical visit also.
Right.
Jumping ahead, let Seth say what happened.
Sure, yeah, so they took you guys took a couple dozen docs. It was 17 attendings, 2 PAs, and then 13 upper level residents, and had them do a couple cases. It looks like it was interesting. It was some kind of basic cases, but with a decent level of complexity, and a lot of them would be patients who needed more than one thing. So poorly controlled hypertension, gout flares, newly diagnosed diabetes, gonorrhea, and H. pylori infections where you need multiple medications. And I also love this, that included 2 scenarios designed to provoke common look-alike or sound-alike medication errors, hydroxyzine versus hydralazine, and risperidone versus ropinirole, which to me, I mean, I make mistakes in the EHR all the time, and it's just so easy to because you're already doing so many things and there's so many different things I'm thinking about, which really, I'm not an expert at all in this usability field or where EHR errors come from, but to me, I know I'm I'm already making thousands of decisions on a shift. So if there's one more little step of clinical decision support for when I say, like, I have this patient with gout, I just click on the gout that I already diagnosed them with, and it just presents me the list of recommendations. That's, even if I'm making the same number of decisions, it seems that much easier for me.
Yeah, I'm just wondering, in that circumstance, I take you at your word, but if you have two similar kinds of names and they're adjacent to one another in a drop down, whether there's still an error rate there.
Oh yeah, I'm sure there's probably still going to be errors, but at least if I don't have to think, wait, which drug do I want to do because it's gout? It's like, oh, here's the it's those 2 steps board questions where it's, hey, you've got a patient with X. What's the common medication error that goes with this diagnosis? And we have to do like 3 steps in our head. If some of those steps are already kind of scaffolded to us, that seems to make sense.
Totally agree. And it's a good thing probably that LASIK isn't next to Lasix in the drop-down med menu, right?
Right. So I'm going to give a meatball here. So Pam, what did you find with error rates for the different systems?
So for the error rate for our system was significantly better than that for both of the other systems combined. So when we looked at error rate, we actually combined the vendors to do versus the prototype. So our system was significantly better. The vendor systems, there were typical sort of medication errors. So dose errors, route frequency, situations where structured fields didn't match what was in the patient instructions. All different kinds of errors that normally occur happened in the vendors, whereas in our system there was much less than that, because for the most part we were handling drug interactions, allergy interactions, all those patient factors up front, so that they weren't able to kind of make those same mistakes. And we were actually pre-populating dose, route, frequency based on the indication and those patient factors as well. So it was harder. It was just harder in our system to make those mistakes.
Nice. And those kind of guardrails are always interesting to me. There just seems to be so much unrealized potential in EHRs with stuff like that. And I noticed also that in the commercial vendors systems, the docs used higher levels of third-party references or looked at reference material more. I know, like, even meds I use all the time, I look up doses or durations all the time, and the more that's kind of in there, but like every few months I go back and claim my up-to-date CME credit, and because we have an institutional subscription, and it's like I look up the dosing for BV meds all the time.
Yeah.
Right, and you're doing that through the EHR through the up-to-date link on the upper right or something?
We can. I happen to usually just have a browser open.
Got it. Yep.
That was particularly true for our scenarios where there were multi-drug regimens like gonorrhea and H. pylori. All of the docs were looking up those. They may be, somewhat frequent for some of the docs, but it's still one of those things where they have to look it up. So that was, part of our requirements when we were building the prototype, that it would be able to order all of the drugs necessary at the same time, or propose all of the drugs necessary at the same time.
Yep.
And I don't know whether we've shown one of the screens, either the figure from the article or the e-figure from the supplement. If you guys can put that up, if you haven't already, or re-put it up. It's really an elegant interface, it seems. But one of the questions that I didn't get a sense for from looking at the pictures was whether you solved the kind of the alarm or the alert fatigue that happens when people click things and these EHRs spit back. Are you sure you want to do this because the patient had a creatinine that was too high? It seems like you guys kind of went by pre-populating the information, you kind of prevented those pain points for the ordering docs.
So that was the idea. We put all of that up front. So if there was a drug-drug interaction, the physician was warned in the list, the drugs of choice list, it was a not recommended drug. So they saw that before they were, even ordered the drug. So the idea was that we would prevent some of those alerts. Now, we didn't have those after the fact alerts built into our prototype. They would have received them if by chance they ordered something that still wasn't appropriate. Right. Mm-hmm. And in the vendor systems, they still received any of the alerts they normally would.
Yeah. And then I would have to ask, with a prototype like this, do you have a design, or would you imagine that you'd still be allowed to kind of work around and override or do what you want as a strong, independent American physician?
Yep. So one of the design requirements, user requirements, way in the beginning that we wanted to make sure that we incorporated was flexibility for the physician. We wanted the physician to still be able to have the autonomy, order sort of whatever they wanted to a degree. So we made it so that they could still enter a drug and just order it right there if they wanted. They'd still, like I said, receive the same kind of alerts that they would in their normal EHR, and they could accept or override as sort of the institution had it designed.
So the JAMA network gets a lot of stuff from a lot of institutions about behavioral economics, and this is kind of a little bit more theoretical, but this seems to me a good example of nudges, which Cass Sunstein wrote about, and which a lot of behavioral ec groups are writing about, which is creating kind of default options within clinical workflow that kind of tilt or tip clinicians to do the things that the system wants them to do because it's higher quality care. Did you have that? I didn't see that theoretical background in this paper. It's not that important, but I was wondering whether you were coming out of that tradition.
Yeah. We didn't look into behavioral economics too much, but yes, I mean I've worked on a couple of projects that they're starting to use that much, and that's essentially what it is. We are sort of nudging them, saying that these are some of the better choices based on this indication and this patient. These are some are not so good choices, but we're not sort of forcing that on them.
Great.
All right. Well, I think that covers it. I want to thank you so much for joining us. It's been a lot of fun. Great to have a new feature with new faces on board here.
Yeah, thanks very much. Bye, guys.
Take care. Bye.
Great.
What's next?
Great. So moving on, outcomes of patients 65 years or older after out-of-hospital cardiac arrest based on location of cardiac arrest in Japan by Okabayashi and colleagues.
Okay, so this is kind of both public health and regionalization of care.
Right.
What did they find? Tell me what they did and what they found.
So what they did is they looked at the All Japan Utstein registry. Every country basically has big registries for cardiac arrest care for what happens to the patients. They looked at the 233,000 patients with cardiac arrests age 65 and older from 2013 through 2015 in Japan. Basically looked at all of them and kind of saw what happened. Their main question was based on where did the patient arrest? Were they in a residency? Were they in a public place? Were they in a nursing home? And how are the outcomes?
A residency meaning a home, not a training program.
Right. Yes, exactly. Yes, for a doctor's watching. Yes. So whether they were in a private residence, like a house or an apartment, or they were in a nursing home or in a public place.
Okay. And I would expect that the closer they are to public services, the more likely their EMS will get there quicker and apply ACLS or defibrillation or so on.
Yep.
Is that a proper instinct in this instance?
Yeah. So this reiterates a lot of what we've known about cardiac arrest, and that if you arrest around bystanders who can provide CPR and, more importantly, call for activate the chain of survival,
right?
Then you're more likely to do better. There's probably some confounding there that healthier people are probably more likely to be out in public. So people in public with better protoplasm are probably more likely to be able to survive a cardiac arrest. But if you arrest at home alone, which I think 2/3 of the patients in the study did, and basically there's no one to do CPR, there's no one to call 911, you're less likely to do well.
Okay. So, I mean, it provides some guidance for the health ministry in Japan in terms of kind of how to distribute services. Seth, it reminds me, I've heard, and I actually never really looked into it. I think it's in Israel or some other setting where they're trying to test out a system that's basically like Uber or Lyft for ACLS. Basically, they're training folks, lay people, to do defibrillation, and then they carry their phones or devices with them, and then when somebody arrests, they get the closest person to the event. Have you heard of that?
Yeah, I've heard of that. I think there's an app you can do with that in the U.S. It's basically crowdsourced. From what little I know about it, I don't think it's at a critical mass where you can rely on that for anything.
Right.
But it's certainly interesting. The kind of somewhat surprising thing to me, I guess there are kind of mixed findings on this, was that patients in nursing homes did much worse than patients in public or patients in private homes.
Right.
On the one hand, they have medical staff around them, which I guess is a good thing. On the other hand, people in nursing homes tend to be older and sicker, which not surprisingly is poor protoplasm. We were discussing this the other day on Twitter, a couple of us, and I think that's what really came down to me is people at home are probably healthy but don't have bystanders. People in nursing homes are probably less healthy but do have bystanders. People in public are probably somewhat healthier and have bystanders.
Right, that's a good way to kind of categorize it. And you've been in the ED when you've gotten transfers from skilled nursing facilities. They can administer ACLS and they have defibrillators, but there's only so much they can do given staffing at the kind of the average overnight nursing home or skilled nurse SNF.
Right. And also not terribly surprisingly, one of the other things that correlated with patients doing well was being shocked by an AED. So patients in public who arrested and had a bystander run, get an AED, apply it, and shock it did better. Of course, people in shockable rhythms, so VFib and VTAC did better as well, with a whopping adjusted odds ratio of 35, which was only from 30 to 40, so relatively tight at that magnitude, which is pretty impressive. You don't see numbers like that a lot. Interesting enough to me, PEA still had an odds ratio of 7.74 compared to asystole.
Really?
Yeah.
PEA is pulseless electrical activity. That's the flat line.
Right. And usually we lump kind of shockable rhythms and non-shockable rhythms and don't see that much of a difference between PEA and asystole.
Right. So I don't know this literature that well. Is there anything that comes out of this because it's in Japan that might be different from other countries? This seems all intuitive, like it could be in any kind of U.S. state or Canadian province or any country.
No, nothing that I noticed that was shockingly different. The authors use the term super aging Japan, that Japan's demographics, which I'm not familiar with outside of the context of this article, to be honest, is just they're getting a much grayer population than as much as the world is graying. In America in particular, Japan is apparently super aging. And if you look at figure 2, not surprisingly at all, the older you are, the less likely you are to survive a cardiac arrest. And this kind of reiterates that across all 3 of the venues they were looking at.
Got it. And as you said, Japan has a bunch of super agers, so they, they reach. They have a lot of centenarians.
Right. Yep. Yeah. And again, their table 3 is pretty interesting, where it breaks down the different odds ratios, the different factors they looked at. And again, it reiterates that age is bad for your health. There are no gender differences. We talked about the nursing home, their location differences. The bystander CPR odds ratio is only about 1.25, but bystander witness overall had an odds ratio of 3, meaning that there was more of an effect of having a witness around than that witness actually thumping on your chest, probably so that they could call 911 and get professionals there. Of course, bystander CPR is important. We should teach bystander CPR. More people should do it appropriately. But the effect seemed to be, the way I'm interpreting this, and I certainly could be wrong, but I'm inferring that means having someone to call 911 is one of the biggest factors.
Got it. Yeah, and most of these, except for the shockable rhythm, the VFVT that you mentioned, most of them are statistically comparable in a particular way. Odds ratios of 1 to 3 in terms of 1 month survival by sex, location, bystander witness, stratified by these variables. So it's good to know.
Yeah, yep. And of course, delays in EMS response time for every 1 minute increment that EMS is away. There's an odds ratio of 0.91. So basically, roughly 10% decrease. You're not going to, it's not like you're dead in 10 minutes, but just, very small incremental linear decrease in survival as transport times are longer.
I don't see the difference here, and I may have missed it, between urban and rural.
I don't think they analyzed that directly on this one.
Okay. You can kind of imply it by some of the variables that they use, but that's always an issue because you assume this isn't just Tokyo and Osaka and the large cities, right?
Right, exactly. But it's interesting because, as much as we talk about how rural areas are spread out and it's very hard to administer a big regional system there, the EMS covering everything, cities are dense and you can have a big network there. And we have, great response times usually on the order of like 8 minutes in a city like ours or New York. But there's also terrible traffic, lots of cars in the way, and, navigating up 5 flights of stairs in an apartment building and things like that, and lots of other challenges.
And this reminds me of a research letter that we published in JAMA about 18 months ago that demonstrated the timing efficacy of sending an automated external defibrillator by drone to a distal region. And the drone was there and kind of administer to a simulated patient in significant minutes less than EMS took to get there.
Yeah, and I think it's the combination of getting the AEDs to people and getting people who can use them, which is really interesting to me, because I think the main finding from the PAD trial, the public access defibrillation trial, which is a big multi-center study that showed that AEDs work, is that you need to basically be in a big public place. Like, they work best in a place like an airport where there's lots of people around who could witness the arrest, run and get the AED and use it. Having it in like a restaurant or an office building where the concentration of people and the likelihood of arrest are not as favorable isn't there. So 2/3 of people die basically alone at home. Having an AED there is not helpful. So it's not worth putting in a multi-$1,000 electrical device.
Right.
And it turns out you can't just use a taser.
Right. And we have a comment from Min. You want to take it?
Yeah, Min says PEA isn't asystole, it's electrical activity, but no palpable pulse. Yes, thank you, Min, for ACLS explaining.
Okay. Right. So forgive my misstatement.
Yeah.
Okay, so that's a great paper. What's the third one for today?
Good basic stuff. So the next one is Association of a Risk Evaluation and Mitigation Strategy Program with Transmucosal Fentanyl Prescribing by Will Fleischman and colleagues. I will admit my COI here that Will Fleischman's a friend of mine, was a year behind me in residency in New York.
Is that right?
Yep.
And Josh Sharfstein, who's a co-author on this, is an associate editor at JAMA, so that's another COI.
Yeah, absolutely.
Do people know what REMS is?
I think people know a little bit about REMS. So REMS, the Risk Evaluation Mitigation Strategy, is a program the FDA implements when there's a drug that might be, I'd say, above or higher than average risk than a typical drug. So that prescribers need to have some sort of extra, basically FDA compliance training. The example I remember is the retinoic acid for acne.
Accutane. Right.
Yeah, and I knew that for a long time, then forgot it until a few months ago when I tried to refill some for a patient. The pharmacy called me and explained and said, you can't do this. You haven't done the training. You're not in the system. There's a whole thing.
Right. and it required patients, patients of reproductive age to document that they were on 2 forms of contraception. It gives the FDA authority to require manufacturers to develop interventions for drugs and drug classes that pose risks. Those include communication plans for physicians, elements to assure safe use, and other kinds of restrictions as needed to kind of mitigate risk.
Yeah. So this one refers to transmucosal immediate release fentanyl. So basically, what I think of mostly is the fentanyl lollipop class, because that's the stuff that was in hospitals when I was in my training.
Right.
But there's also sublingual and buccal fentanyls, as well as fentanyl sprays. I think sublingual sprays are the big ones now. One of the ones they talk about in the paper is Subsys, is apparently one that's now kind of dominated the market since 2013, is a fentanyl spray. And basically, not surprisingly, mucosally absorbed fentanyl can be pretty hefty doses. It's pretty potent. It's a very potent med, as we know, even though it can't aerosolize. The issue is that these are only FDA approved for patients who have cancer and who also have opioid tolerance, and basically are already supposed to be on round-the-clock opioids. The potential safety issue with FDA approval of something like that is that just because something's FDA approved doesn't mean you can only use it for that individual indication. Once it's approved for one thing, a doctor can prescribe it for anything. So basically, the FDA worked with industry to implement this REMS program so that doctors needed to have training on who this was supposed to be for, and then the industry group, the TRIG is the industry group that monitors it, is supposed to kind of assess it and see how things are going over time.
And this was presumably in response to the opioid epidemic generally, rather than particular risks from this drug class, or was it both?
I think it's a mix of both.
Okay.
So, yeah.
Great. So this study is kind of looking at the effect. We can't really say effect. It's a time series analysis, but it looks at prescriptions in different patient kind of categories of these transmucosal immediate release fentanyl products before and after institution of the REMS program.
Yeah, and basically what they did is look at the Medicare Part D, the Medicare prescribing database basically look at all of the prescriptions in Medicare Part D from 2010 through 2014, and what kind of TIRFs were prescribed, and then kind of on all the graphs, which we'll run through a couple of them, show just how those levels changed. So I'm going to keep Eric on his toes a little bit on this one. So first is figure 1, just the overall prescriptions per 100,000 Part D participants by each individual drug, and you can basically see a relatively linear move across from 2010 to 2012, and then the dotted line here is when the REMS program was initiated, and you can see a pretty decently sharp drop, and then it starts creeping back up again, especially when Subsys, that one of the sprays I mentioned, gets introduced and gets apparently was aggressively marketed, and I don't know the details, but the CEO of the company that made it was like
pled guilty.
Yeah, pled guilty, went to jail for wire fraud, like all the badness.
For bribing somebody, right, to prescribe for off-label indications.
Yep. But you can see the marketing, illegal marketing apparently worked, and they basically dominated the market and took over the majority of the market by 2015.
But before you move on and graphs, what's interesting to me is that drop happens before institution of the REMS program. It seems like
it looks like it started.
Docs seem to pull away in the 3 to 6 months before.
Well, that's what's always interesting to me with these sort of policy papers, trying to look at the impact of a policy is how much of it is chicken or egg, and how much is the implementation of, say, a state law on naloxone prescribing or something like that. Really just show that the tide is turning. There's now a critical mass. There's a lot of docs have gotten interested. There's patient advocates, et cetera, and it's bubbled through the state legislature, or in this case, the federal regulatory agency, and that we talk about how you can't say cause and effect in studies like this, and you really can't, because maybe part of the reason why there's critical mass for FDA to implement a REMS program was because the pendulum had swung so much already that prescribing was already on the way down.
Right. I guess I have, in these association studies, that they're ripe for all sorts of kind of interpretations. I just have to wonder whether people know that in a few months they're going to have to go through training and then go through lots of headaches that they didn't need to before. So they're like, I'm going to shift you onto some other product so I don't have to work as hard as I previously didn't need to in order to maintain you on this drug.
Right. Well, that's the perfect segue to figure 2. Which basically, if you look at the overall monthly prescribing of the first prescription for TIRFs on patients, the monthly prescriptions per 100,000 Part D participants just for the TIRFs. Basically, if you look at when you cross out all the points, there's a slow gradual drop before the REMS program. Then in 2012, there's basically a decent sized drop in the level, and then it starts to creep back up. By 2014, it's basically back where it was before. And one of the speculations, the hypothesis the study authors propose, is that how much of that was just the prescribers who wanted to get on board with the possibly inappropriate TIRF prescribing, say, all right, we made it through our program, we did it, I'm now up to date, I did my whatever compliance training and stuff like that, now I can start over-prescribing again. And that's the people made it through. And they also noted that the number of prescribers who are prescribing to patients who don't have cancer and the patients who aren't opioid tolerant is a relatively small number of prescribers.
I guess I also can, giving the physicians the benefit of the doubt, there are patients for whom, quote unquote, nothing works. They need the strongest pain medicine, and they try to kind of dial down or shift to alternative classes. And one could imagine, and it's purely speculative, that over a couple years, their patients said, like, doc, it's not working, I need more. So they said, I'll train up, I'll do what I need to give you what's available, which is the strongest thing, which are these TIRF products.
Oh, yeah, absolutely. I mean, I'm both a cynic and an optimist, and I think we absolutely have an opioid overprescribing problem, and we absolutely have an oligoanalgesia problem at the same time.
Oligoanalgesia, I love that.
Yeah, it's a fun word. Last graph I wanted to show from this one is figure 4, the monthly percentage of initial TIRF prescribing to patients without known opioid tolerance. So this is the whole point. This is the patients who aren't tolerant of opioids, who, they might take 1 or 2 sprays of fentanyl and pass out, and that's a serious problem because I learned in med school that breathing is important. And you see basically right after the REMS initiation, the curve does drop down, and the prescribing to patients without known opioid tolerance did drop a fair amount.
Right. So that is a patient class in whom this intervention appeared to be effective, and I say that very cautiously because we can't prove effect.
Right. And then I'm going to mangle up all these numbers because there's a lot of numbers, and I'm not going to rifle through all my papers anymore. But it's interesting. I think it was 2/3 of the patients that they found didn't have a diagnosis of cancer that was documented that they could find in Medicare data in the last year. That doesn't mean they don't have it. There's lots of reasons why we're bad at getting diagnoses into these databases. It might have been in a prior year, or just may not have made it into it for whatever reason. And also a substantial amount is 80% were younger than 65 years, which at first didn't really register with me, and then I realized this is Medicare data. So everyone in Medicare is either over 65 or has a disability, including or ALS or end-stage renal disease. So 80% of these were not in Medicare in tradition just because of age. So they either had ALS, end-stage kidney disease, or disability.
I see.
Which is really interesting to me.
That is interesting. That's an unusual patient population, and not the ones we easily imagine coming into the ED or primary care clinics. I mean, we have lots of those, of course, also. But not the majority of people who we think of as requiring kind of, for back pain.
Yeah, and if I remember correctly, it's only about, I want to say, I'm going to be conservative here, only about maybe 20% of patients in Medicare enrollees are under 65.
Got it.
So this is a vastly overrepresented group. That being said, there are patients who either have a disability, end-stage kidney disease, or ALS, or a relatively sick group.
Okay. Interestingly, this is a good companion to a piece we published last month in JAMA that was the assessment of the FDA REMS program for TIRFs. It actually looked at, kind of took a different look at the problem. And I misspoke again earlier today. Josh Sharfstein, our associate editor, was on this JAMA paper, not on this JAMA Network open paper. But I encourage everybody to just do a search for TIRF, which is the acronym for Transmucosal Intermediate Release Fentanyl. And they were looking at basically US FDA documents and the mechanisms that the FDA used to assess whether this REMS program was effective. And they ended up concluding that a substantial proportion of pharmacists and clinicians, despite all of this kind of heavy lifting and aggressive intervention to educate them about the proper use of this drug class, weren't educated and were still prescribing in substantial amounts, not majority amounts, but substantial amounts to patients who were not opioid tolerant and other patient categories who didn't need them these drugs according to indications. And they say, despite these findings, the FDA did not require substantive changes to the program. And we have a good editorial by Greg Kerfman, who's a JAMA deputy editor, and his colleague Amit Sarpatwari, who kind of talks about the REMS program in context. Talks about the problems with off-label prescribing and the guilty verdict that we talked about of the INSYS CEO, and say that if the FDA is going to continue to rely on REMS, better systems are needed to ensure that the programs work. So this is another instance of a great idea and necessary intervention, but we don't always know if it's having the effect that we want. Certainly there's that one signal in the JNO paper that shows that it went down in one class of patients we'd want it to go down in, but otherwise maybe not.
Yeah, and I thought this paper was really fascinating because it wasn't just about prescribing behavior, but also just basically survey data where they sampled some docs, and these are docs who are happy to answer a survey for the FDA, so it's a not the most cynical group. And so it was kind of shocking numbers of like 10 or 15% who even after they had done REMS training didn't realize or did not answer correctly the questions about which patients were supposed to be prescribed or who was it, or pharmacists didn't know who was approved for, whether it was approved in general, and that basically the REMS program, not only did it not translate into behavior changes, but there were still knowledge gaps about it. And I mean, I'm pretty cynical with stuff like this, and it's just unfortunate that basically a lot of FDA regulation and stuff like this is just relatively toothless, and it's supposed to be industry self-policing. And as your conviction mentions or implies, industry is really bad at self-policing.
I was not convicted. Let me just be clear about that.
I'm not allowed to comment on that. But there's just the industry is really bad at self-policing this stuff, and this is people getting hurt.
Right, and there's news releases every day this week about Purdue and the Sackler family, and it's not a generous side of kind of our industry that we're trying to help patients.
Yeah, and the way the numbers translate too, whereas I think it was like somewhere around 10 or 15% of the docs who answer the questions wrong about who should be prescribed these medications, and they do something like 30% of the prescribing. So it's in many cases, there are docs who are bad actors who are overprescribing. I think a lot of us get annoyed or afraid that the FDA is going to come out at us because we, did more than a 3-day supply or blah, blah, blah. Like there are guys selling 180-day supplies out of vans outside of Walmarts for things besides cash. So,
On that note, what's the good news? What are some other interesting papers in last Friday's release?
Great. So a bunch of interesting papers this past issue. So there's a great headline paper on changing perceptions of the harm of e-cigarettes versus regular cigarettes in 2 national surveys between 2012 and 2017. And basically, the perceptions of harms associated with e-cigarettes is catching up with the perceptions of harms about cigarettes, which is probably appropriate as well. Bad news is that more people are smoking in Asia, and it's leading to more mortality. There's a paper on mortality in Asia.
That's where I think, the U.S. tobacco industry has shifted and kind of morphed into e-cigarettes, into kind of cigarillos, all these things, into chewable tobacco, and into emerging markets.
Right. Yep. And emerging markets in places, I'm getting out of my depth as far as details, so apologies if I get this stuff wrong, but you get places like India, China, the Philippines with billions of people and who are gradually increasing their income level and now have disposable income to spend on cigarettes. It's increasing mortality and projected to increase it substantially. On the plus side, this is fascinating. There's a 72-year follow-up from an RCT and a youth crime prevention program, which I just love stuff like this. Like, this is really long-term data where there's an RCT and checking out mortality decades later. I don't know all the context, but based on reading the article, there had been some suggestions that there were increases in mortality from the intervention arm and that the youth delinquency programs actually somehow were related to increases in mortality. And this shows that if you leave your time window out long enough, those increases go away, which is good. So we can continue doing effective crime prevention programs.
Right. That reminds me of that film series, 42 Up, 49 Up. Are you familiar with that? They actually interviewed these kids in a British boarding school at age 7 years and then followed them up every 7 years. So it wasn't really an intervention. It's really a documentary, but it's the longest running documentary because it follows this cohort over time, and it really is kind of poignant because it shows all the things that happen to humans as they move through life stages.
Nice. Well, not a documentary, but Ethan Hawke movie was really good too. Next, social risk adjustment of quality measures for diabetes and cardiovascular disease in commercially insured patients. This is interesting because there's this big debate among health economists and health policy people about whether or not to do adjustment for socioeconomic confounders for different pay for performance and quality metrics. And basically they found that doing social risk adjustment had some modest effects and overall just didn't make that big a difference. This is not going to be the nail in the coffin with that debate, but it's some interesting data points.
So just to be clear, like the sicker patients with heart disease or the sicker patients with diabetes, some of that illness is kind of statistically attributable to other non-physiologic kinds of socioeconomic exposures.
Right. And then from the provider point of view, if you're a hospital or a clinic in an area that has a more disadvantaged population, should you be punished because you can't hit quality metrics because your patients are sicker, more complicated, and have more vulnerabilities and aren't able to quit smoking or bring their A1Cs down or something like that.
So not so much a clinical question, but and not the nail in the coffin, but an important kind of contribution to how to study these diseases.
Right. Also, not surprisingly, there are sex differences in symptom burden, treatment strategies, and quality of life in patients with atrial fibrillation in Japan.
Okay.
What else? This one I liked. I'm well out of my depth on this one, but they compared the oxygen saturation index compared with the oxygenation index in neonates with hypoxemic respiratory failure. I like this because you could basically use oxygen sats instead of invasive measures of oxygen to get the same kind of information on sick vent-dependent kids.
Okay. And these are neonates or not necessarily?
These are neonates.
Yes.
Yep. Right.
So the pulse oximetry is...
Pulse oximetry worked well compared to this oxygenation index that required invasive oxygenation
Not my
measures.
area either.
Yeah, but I like it when we're able to do things without poking patients as much, as effectively.
Yes.
Also another one well beyond my skill set, but association of deferred versus immediate cord clamping with severe neurologic injuries and survival in extremely low gestational age neonates. And basically they found that you can essentially do, the editorial calls it like a placental transfusion, and that really sick neonates in this ELGA group, if you don't clamp the cord, they basically get transfused from the placenta, and it helps them.
Good thing.
Which is good, and it turns out it helps the kids. They don't have neuro injuries. and it helps their survival, which is good. That being said, the fraction of them who need resuscitation seems to be very low, and it's like, you know, whether or not you make a split second decision to clamp or not, it seemed very complicated. So again, probably not another nail in the coffin.
Because I may be off, but from my old days in medical school, I thought they get plethoric and hyperbilirubinemic, and then, you know, are at risk for connectorous. But maybe I have the timing off on that.
Sure. Yeah. Okay. Well, and that's the question: is if most kids are going to be okay, and you want to clamp them to avoid those problems, but the small fraction of kids who are sicker who need that, it benefit from not doing it, and that's why we need more data, basically.
Okay.
And also why I am not a neonatologist. Also, just to jump back one more week because I was out of town, two interesting papers that I really liked: the prevalence of bacteremia and bacterial meningitis in infants in the first 2 months of life, and basically found that, not surprisingly, the rates of serious bacterial illness and meningitis were very low, but about half as low in the second month of life than the first month of life in kids with fever, which is good, which reiterates what we know. But basically, you know, there's all the debates between the Mayo and Rochester, and is the Philadelphia the third approach? I don't know, for fevers in little kids. And, you know, this is, again, one of the situations where if kids do just as well when we poke them less, that's good.
Right. And if you're visiting your newborns, wash your hands in the first 6 months of life.
Yep, and get your shots. Lastly, trends in the use of common words in patient-centric language in the titles of medical journals.
Right, I like that
from
one.
1976 to 2015. And basically, they looked at like all the different words in a whole bunch of medical journals over 40 years, and found that we're using more evidence-based medicine language and more patient-centric language. So, you know, there's these anachronistic titles when you look back about, you know, like such and such in a diabetic. It was where now we'd say is in a patient with diabetes.
Right, where the patient was conflated with the disease label, and now it's a person with the illness or condition.
Yep, and you know, it's always nice little nudges that patients are not just disease-carrying vessels, but are, you know, people with hopes and dreams and things.
Right, and this one actually has interesting word clouds, which is just visually interesting to kind of see the most common words that came out of this kind of NLP. I think it was natural language processing of all of this, the text of these titles of these many articles across the journals.
Yep. So I think that's it for today. Thanks for joining us and sticking with us if you made it this far. Of course, be sure to follow us on your various social media platforms: Twitter, Facebook, LinkedIn, YouTube at JAMA Network Open.
Right. Remember that we are translating all of our titles into Spanish and Mandarin Chinese for those of you who are interested in that. And we now have a podcast. Editor-in-Chief Fred Rivera and Deputy Editor Steve Finn pick 2 articles from each month's release to kind of talk about them. It's kind of like an audio editorial. You can go to the issues link on the homepage and find that within line in the electronic table of contents on that page.
Great. Well, thanks again for joining us. Take care.
Always a pleasure. Thanks for joining. And if you have questions following the live broadcast, leave them in the comments and we'll try and respond.
Right.
See you next time.
Bye.